Hello, Ash. It's good to see you. Thanks for joining this series of podcasts. Maybe we start by you introducing yourself a little, and then I've got a couple of questions that I hope we will find stimulating.
Thank you, Richard. Thank you. And I hope you get over this cold very quickly in that beautiful surroundings behind you. So my name is Ash. I'm a practicing clinician over the last 35 years now. And in the last 10 years have sort of migrated more towards what I call root cause analysis medicine. I think now the term is longevity medicine, but when we started this, it was purely about finding out the root cause of problems on the basis that if we can sort it out at source, things are resiliently cured or treated or managed rather than suppressing an expression of disorder and disease, which is where the conventional model tends to stay most of the time.
No, I like that. I like that description, root cause analysis. I'm familiar with it in other completely different contexts, figuring out what is the basis for error, or in this case, ill health. So maybe you could take a moment to describe how you use that approach to personalize the care that you give to your clients.
Yeah. So I've been involved in a lot of health screening in my career. I used to run at the London Clinic Health Screening Unit some years ago. What I found was that at that point, it was, to find root cause, people thought you just needed more tests and more detailed tests. And the bigger hospitals that offered the best MRI or the best angio, it was patients perceived this to be linked to root cause analysis. But in fact, through experiential learning, what I feel root cause analysis is more of a humanization process where you spend time speaking to patients, tracking their history from the point they're born to where they are now. And in that, you find there's a lot of information given, and rather than focusing on the testing, we focus on what patients perceive or believe about their illness, what they think is causing it. And the great thing about medicine is that if you listen to patients carefully, they'll kind of give you an idea of what's going on. And if you listen even more carefully, they'll actually tell you the solutions too. So it becomes the easiest job in the world.
Well, a rather basic question then. How long is that initial discussion?
It can't be shorter than 90 minutes. It really can't. And partly because you don't want to be appearing as a clinician as someone who's just taking a systematic history. It's got to be a conversation. It's got to be totally patient-led, and patients need to feel comfortable. And the body language of the doctor is important in these situations. So if the doctor's relaxed in terms of time, not thinking about the 10 other patients in their waiting room, not thinking about all the notes they have to write, they're in the present, and we're humans, and patients sense this, that if they know you're actively listening, they're more likely to open up over time. And
I just did a bit of research, sorry to interrupt, but just a bit of research on the number of different biomarkers we now have available to us if we want to run tests. And you're saying that's not your starting point. Can you give us some examples of things you've discovered, obviously without the patient names, but things you've discovered in those conversations that you might not have expected when the conversation began?
Yeah. So when you track people back to their history and their narrative, often people displace things that have happened to them early in life, the first 5 years of life, and then their teenage years. Examples are, I had a 3-week infection and I was in bed for 3 weeks with glandular fever. I was very anxious in school. I was bullied. I had this traumatic injury. My parents got divorced. There were issues with alcoholism. All these things that people have kept under the carpet. And when they're opened up in this way, we can then probe a little bit more into why they behave like they do now, and trying to make them understand the links that are associated with what they don't actually feel is relevant or important. But most importantly, often these traumas are hidden deep in the limbic system. It's almost like a child hiding under a bed, thinking if they can't see the world, well, the world can't see them. And this creates triggers. It creates sympathetic drive in the body, and we can't underplay it. And the only way you can actually get it out is actually actively listen and then make the links. So with this, we found patients who are sort of having anxiety disorders, insomnia, complex medical disorders, autoimmunity. It always links to a process of trauma. And the body just gets wired in a certain way. They often ask, why me and why not somebody else? And often when we show them these links, they start to understand. And once you get this, you'll get concordance and you'll get buy-in in terms of the treatment plan.
Now, I suppose a lot of people listening to this will say, well, I understand that stress can come from, mental conditions that might be buried in my past, and that stress is bad for you and it shortens your life and so on. But I think you're saying it's a little more complicated than that. And the physical symptoms that someone might feel could well be driven by psychological background.
Yes.
In a way that's rather more subtle than that.
Totally. And I my starting point is there's no such thing as psychosomatic illness. The psychology leads to impulses going down to the physiology and manifesting. So the two are entirely linked. And I think this is really important to explain to your patients that you're not making it up. This is real, but the brain is convinced that you have a problem, and we need to understand where that has come from. So I feel the other thing is you can rationalize this in your conscious mind. We know that if we can exercise, eat properly, sleep, we'll be fine. But the reality is it's the unconscious mind that's driving this, not the conscious. Because the unconscious mind says, yeah, you can say what you like, but I don't believe you because I'm looking down at the system and the adrenal glands working overtime, the gut's broken, the liver's toxic, and you've got no hormones. So I don't believe that the saber-toothed tiger has left the room yet. And this is...
do, in fact, therefore, run some tests to demonstrate some of those connections?
Yes, I think we live in a world of evidence-based medicine, and I'm of the belief that 98% of the information is gained on the history and is confirmed by the testing we do. So we don't do the test to find out what's going on. We do the test to confirm what we found out in the history.
So I think that is probably the reverse of what many practitioners do. As I say, there are so many tests now that can be run. Sometimes there's a financial incentive, usually there's a financial incentive for practitioners to run more tests and charge the client for them. So this is a distinctive approach. Anything more you want to say about the personalization aspects before we explore the other question I have in my mind?
Yes, I mean, so with the personalization, everybody's different. Everyone's signature is different. And this is why the history is so important. As I've said, the tests we do baseline tests on platform bloods and hormones and body composition indexes, but just to reinforce the issue of what we found on the history. And I think the key thing here is time is important, and the best co-pilot an individual has is themselves. So if we can increase this awareness in an individual, they will be resilient. They won't hand over their responsibility to doctors. Going back to testing, it's not just a financial incentive. I think it's a defensive incentive. When I did A&E, we couldn't get CTs and MRIs for love or money. So we had to listen to the patient and triage. Now people get their CTs and MRIs before they see the doctor. So I feel that we're losing our skills as intuitive clinicians, and therefore relying heavily on outside tests. So I think it's not just about finance; it's the way the NHS is working under pressure.
Yeah, and it's interesting you've raised a point in my mind that we probably shouldn't pursue. But I'm also very interested in artificial intelligence, and what I see happening is AI replaces some of the rather basic tasks that people do. Maybe even taking histories and so on. And so there'll be distractions. And the question is, how do people acquire the kind of expertise you've acquired over many years? Will they in fact be future Ashes? So, but let's not go down that rabbit hole.
Just to speak to that, Richard, I think it's a very valid point. I mean, AI is affecting all industries, and including the healthcare industry. But like with everything, my senior partner used to say to me about searches and audits, he goes, rubbish in, rubbish out. Ultimately, you've got to feed AI with the correct information. You have to understand what you're asking of it rather than delegating your brain to it. And that's the danger. I think, it's a absolutely phenomenal tool if used correctly. It will enable us to fast track information, but you've got to feed it correctly and not delegate the responsibility to it in terms of what you're asking.
Exactly. So let's turn, if we may, for a minute or two to my other question, which is, okay, we've got practitioners of all kinds taking different approaches and trying hard to personalize what they're doing with their clients. And therefore, the field strikes me as being very fragmented, diverse, use whatever word you like. How will this field learn over time?
Well, Richard, we need to learn from our mistakes. Now, if you go onto SNOMED, which is a classification tool that we use in hospitals and in general practice, there are over 300,000 codes now, if you include prescribing, pathways, and clinical diagnoses. 300,000, and it's escalating. Now, how can your average GP or even your clinician in hospital keep on top of all of that? So, we have created a very complex matrix in conventional medicine, and we've been obsessed by labels and pathways and not actually thinking about outcomes for patients. My big concern is that longevity medicine could go that way. Now, if you look at longevity medicine, there are about 200 to 300 potential things you can now do. I imagine by next year that'll go over 1,000 and then escalate at a rate of 1,000 per year. And the worry I have is that people will just pounce on things thinking that's the silver bullet, and it is not so. So at Levitas over the last decade, having naturally grown in this world, what I feel is necessary is a strategy. Patients need to know why they're taking what they're taking and when to take it. There's never a wrong intervention, but timing is important. So in Levitas, we have a strategy. We say that before anything works, we need to build your infrastructure internally, the hormones, etc. After that, we need to detoxify you. Then we can repair you. Then we can renew you. And within each of these strategies is a set of standard operating procedures that will vary depending on your budget, where you live, how much you can afford, but there is something for everyone. So my view is through strategy and a set pathway, we can democratize longevity and stop people getting confused and jumping into all these pop-up clinics for their drips or their cryo or their hormesis in a random manner where they won't get better and possibly sometimes get worse.
No, I think that I share your concern. The question becomes, therefore, if we've got responsible practitioners, and I'm not thinking of these kind of pop-up high street things, there are people who are running clinics across the world. Is there enough commonality in the protocols that you've just described to be able to A, collect what is being done with the client, and B, the outcomes from that?
No, there isn't a collective. And the reason is you can only do what's in your toolbox. Now, in longevity, people are coming in from the personal training world, from the MSK world, from the functional practitioner world. So they're bringing their toolboxes with them. But what I'd like to see is for them to open up and look at this opportunity of longevity to work in a multidisciplinary team. So I feel responsible longevity requires an MDT. It requires a good history and a couple of people in various elements of their work to come in and create a treatment plan, a longer strategy, and they'll learn from each other. And the most important person in the center of that MDT is the patient.
Well, that's a very interesting proposal. I call it a proposal because I don't see it happening everywhere that I go. I mean, we all know that MDTs are very important in the treatment of cancer, for example. You get the radiologist together with the oncologist, together with the radiotherapy expert and so on. So we're familiar with the idea, I think, in healthcare, but the idea of applying that approach to clients in healthy longevity, I think is one that's worth further pursuing. Who would be around the table when that treatment plan was developed?
So the reason why MDTs are difficult is to try and get 7 or 8 people in the same room at the same time is almost impossible. This is where AI comes in. Now, what we're working on, and we've done it with 2 of our treatment plans, one of them is a testosterone restoration therapy. We've fed in the several thousand questions that could potentially be asked by patients. We've fed in calibrated results and how they can lead to treatment plans. And we call it a co-pilot. So you as a doctor could be sitting in the consulting suite and you've got a patient in front of you and you get a bit stuck with what to do with this testosterone level. You can feed it into this co-pilot and the co-pilot will navigate saying, have you done stages A, B, and C? And if you have, this is what would happen. So I feel this is a good use of AI because you can scale it up. You can put expertise in, which can then be updated and this individual would sit just like you and I are online to support this doctor and navigate them through it. Obviously, if there's a situation that is complex that cannot be answered by the AI, it would revert then to a clinician. But the more intelligent it gets, the less that's likely to happen. So I feel standards, platforms can be achieved much quicker than ever through convention, because AI has simultaneously come in, as has longevity. So it's a really powerful opportunity to globalize standards. And I think this is how we would be able to achieve it.
That's very cool, actually. So instead of necessarily bringing around the table, yourself, the nutritionist, the exercise therapist, blah, blah, blah. I mean, ideally, you would bring them all around the table, but as you're saying, that's really, really complex and costly. If you could have those people, if you like, represented by an AI program, then that really works.
Yeah. And I think the great thing about this is you can feed 100 specialists into this and to get a consensus. And I feel it's safe medicine, it's standardized. I feel also it should be available to patients. Patients should understand what their doctor is going to do to them. Our job is to explain the narrative. The pathways can be explained directly through AI. The narrative can change so the language is different, saying you're going to see your doctor for testosterone restoration. This is the standard global pathway. These are the sort of things he's going to discuss, and then he's going to put the personalization in based on that solid platform. I think it's a super opportunity. It really is, to transform healthcare globally.
Well, and I think it does apply to healthcare, not just to healthy longevity medicine.
Yes.
And of course, with the patient's permission, the conversation can be listened to by AI, and it can distill some of the learnings from the consultation.
Yes.
And then it can go forward when the outcome data is available and deduce what was it that we did that worked. So I think that's a fascinating vision.
And the other thing, Richard, is we can bring experts from all over the world for the first time. We need to get out of this cage thinking that it's all within our consulting suite. It is not. The world's open. There's some fantastic people out there, and this is why we need to look at AI properly, responsibly, but also use it effectively.
Well, I think you've, in this short conversation, Ash, opened my eyes, and hopefully to the eyes of the people who will listen to this podcast in two or three very interesting ways. So I have this picture of the AI AI-powered MDT, and you orchestrating this, and the field learning as a result of what that MDT produces and the outcomes from it. So let me thank you again for your time. I enjoyed the conversation, and hope you have a good day, and that this this practice of yours progresses well.
Great. And Richard, vitamin C 2 grams twice a day, zinc 15 milligrams twice a day, and vitamin D 10,000 units for a week, and your cold will get better.
Thank you very much for the prescription.
Lovely.
Very good. Thank you very much.
Take care. Bye-bye.
Hi, Ash. Cheers.